Hello and welcome everybody to another episode of Auditing Antics. So today we're going to be tackling a subject that's a pretty hot topic, both in the medical industry, but also, throughout the news. We're going to be talking about medical weight loss and what this looks like from a compliance perspective when we have a lot of providers that are going in and prescribing medications. Michelle, another thing that I hear from a lot of the providers I'm meeting with and working on, or even administration, is that because it is so popular also in the news and social media, that they have a lot of patients presenting wanting medications and they don't understand what that means. Even the providers typically don't understand what that means from that coding and billing perspective.
Yeah, I definitely agree with that, as this is a journey that I've been on personally with the weight loss and the weight loss medications. It definitely is something that, going into it as a consumer, I don't think you would know all of the details that come behind that, and how your coverage and things like that play into the compliance aspect of the management of weight loss medications.
Yeah, and one thing that I find that unfortunately happens, especially in larger facilities, is that providers that want to do something new, or if something is a newer method in some way or another, or more popular, they're thinking of it more so from that clinical perspective. So, if a physician, for example, has patients who are continually asking, they're going to look at the clinical side of drugs that are available, both approved through FDA, and sometimes, from that perspective, they will also consider things that are off label. And one of the things I'm finding as I'm working with, large organizations on this, even hospital facilities on this, all the way down to individual practices, is that it's happening and administration doesn't even know that it's happening because the providers aren't thinking, oh, I want to prescribe this med. I better go ask compliance. It's just not happening. And, I've personally been trying to get this message out there a lot more, especially over the past year, just because of how often I'm seeing it. So, for example, one thing that's happening in my own work is that I'll be reviewing, rheumatology, or last year I had a large situation with a bariatric clinic who had also implemented a part of a program specific to medication weight loss. I never thought that I was going to see that going into that review because my mind was on the surgical side of things. And then I started to notice this information. So, one of the things that I think is really important to touch on is the way that we can identify this in documentation. So, whether we are coding or auditing, or even if you're, at the administrative level, you need to be aware to have your eyes out, maybe even reach out. This is why external auditing is so important as well. So, as a reviewer, the way that I started to recognize this, and I've been dealing with this pretty steadily for at least a year solid. And the way that I started to recognize this is, number one, the main information coming into, the HPI portion of the note, the assessment and plan, was all directed to weight loss. So it wasn't a situation, sometimes we'll see that the treatment is geared towards diabetes or another chronic condition. But I started to see this in practices where it very specifically was separating out the obesity, the BMI, and then looking at different options, and even putting it into the documentation that, they've discussed this different option. They need to see if it's approved from the prescription standpoint. So, Michelle, that's a really big disconnect as well, is that, we have that component, like I said, of the providers who are not realizing there's a compliance issue. So they're focusing clinically. But then we also have this issue between, what kind of buckets should we put this into? Maybe the billable services, so E&M services on the practice side, versus the completely separate process of pharmacy billing, which usually doesn't even involve the provider personally.
Yeah, so I think that the main area, which I will say this is something I've just recently really started digging into. So you definitely are the expert in this area compared to me. But I think that what you've said is absolutely correct. I think that I see this most in my primary care type audits where they're trying to mix this in as part of the chronic care management for the patient, and it can get kind of confusing, and I think it oftentimes could get missed as something that could potentially pose a compliance risk if the coder or the auditors or administration is not aware that this is an issue. So I think that by first recognizing it's an issue, it can help you put different processes into place in your practice to try to combat the compliance risk that the weight loss management can pose when billing for these services.
Yeah, and that's a good point because I'm going to dive in a little bit here to help from that research perspective, right? We're going to dive in a little bit to what you need to be doing to differentiate between what would be reimbursable through a payer and what would not. But I want to just pause here and talk a little bit about what you just brought up as far as the mixing of management of chronic conditions with this type of situation. So, to better understand this, I think we need to think about the actual medications first. So, a common one we hear from the news, from social media outlets, is definitely going to be Ozempic, right? I think a lot of
Mhm.
us think of Ozempic when we think of weight loss medication. And that's a good example because that's something that is approved for treatment of type 2 diabetes. So, that's not approved for any kind of medical weight loss. But when we have a different medication, a common one that is FDA approved is Wegovy. And just so the viewers know where this information can be found, when you're wondering about the different medications and whether or not it's even reimbursable or should go through an insurance process or a self pay process, what you need to do is look up the actual medication and view the FDA information first. So, with every drug that is approved, you can get on the FDA's website, you can search the name of that drug, and it's going to show you the most recent label for that medication. I'm sure the practitioners are aware of that, but from the compliance side, we need to know to dig in to get the detail about what is allowed from the approval perspective. So with Wegovy, one thing that's interesting about that is yes, it's FDA approved. It does not mean it's across the board. So what we have to do is look to see if the patient has that BMI. I think it's greater than 30. It's either 30 or 31. I think greater than 30. And the other scenario that would be applicable is if they have a BMI of 27 or higher and have underlying conditions on top of that. So, what that means is if your provider sees an otherwise normal, healthy patient at a BMI of 27, 28, that's not as indicated by that FDA label. That would be an off label use. And in this particular situation, we're not going to be able to use that for compliance and support for billing the payers. Now, one of the other things that we have to be careful of, and this is why it needs to be a conversation internally in these departments and practices, because you also have to understand what process your providers are going through to supply the patient with the medication. So, what I mean by that is they could, like I've seen in some notes, they could say, we're going to try this medication. We're going to check first and see if you have coverage under the pharmacy benefits. But there's also different practices that are taking the approach of compounding drugs. So they're either compounding it themselves as a physician, for example, or within a pharmacy, a compounding pharmacy. And Michelle, I don't want to dive too much into that because compounding has all its other compliance and sometimes legal issues attached to it. Pharmacies get in trouble all the time related to compounding practices and the way they're choosing to bill it. But for
Mhm.
the internal conversation, I think what would be important is they need to realize, okay, first of all, what is your goal from a profitability perspective when you're looking at this type of program? This is not just typical fee for service. I'm billing it out and I'm going to get paid for it. So, can you give a little bit of insight from that perspective of the compounding side and what that structure could look like with self-pay programs if, essentially they're choosing to offer this as a really an all-inclusive package as opposed to fee for service like we would with the insurance?
So from the compounding side, the self-pay, this is actually the route that I personally ended up having to go, is the self-pay side. So it was determined finally that my insurance doesn't cover any weight loss related um, services at all. So the setup which which we follow is I go to a nurse practitioner and I pay out of pocket essentially for that service. She still oversees everything, provides me with the compounded medication, manages my overall, she actually does manage my overall health. She checks my labs and things like that, but I do pay out of pocket for all of those specific services. So you would have to look at what is the patient's basically what is the patient's coverage for these types of services before you could determine how they could be billed, whether it would have to be under a self-pay program or if it could be billed out by the payer. So it's something that is really individualized to the patient, even if they have two patients have United Healthcare, for example. One company may choose to cover that service for their employees. However, this other company may not. So you really have to dig down into the individual coverages on these things to determine, are you going to be doing self pay or can you bill the payer for the service?
Yeah, and that actually becomes an issue when I'm meeting with practices or especially hospital facilities or large, multi-specialty groups. Number one, a lot of times administration had no idea that they were doing this medical weight loss, we'll call it. And, so the first step we talked about was looking at the FDA approval, what's allowed to be done from that perspective. Let me give a little more context to why that part's important. So, from the payer perspective, with different payers, there's times that they're going to consider things to be not medically necessary or investigational and experimental. So, a lot of these drugs fall into that particular bucket. And that is how we have that chain that links to even E&M services not being supported for reimbursement. Now, like Michelle was describing, those self pay programs, that's something that takes a lot of thought. As you are structuring a program around this, if you find, for example, that your providers are doing this, there needs to be a pause and you need to think about what's going to happen going forward. Because I know when I'm working with people who already have this set up, they've been giving the patients the drugs. All of a sudden, this comes up. A lot of them would be self pay. Well, what do you do at that point? You have a massive mess. So, from that administrative level, this really takes a lot of thought and planning. And if you are an organization that's thought about it, but has not gone into that space yet, this is the framework of what you have to do before. You have to consider all of these things. And, another thing that I find, Michelle, is that when we're looking at even advertisements, for example, I know for me, I get my mental health medication, which I love and need. Um, I get that from the company Hers, and it is an online telehealth type
Hmm.
platform. And because I get that medication there, I get spammed constantly. And I was receiving ads, around the holidays that said, it's not too late to lose weight, reach out now and you can lose your weight before the holidays or, eat like you want and lose it after, that kind of funny stuff. But knowing what I know from the industry and the compliance side, I can tell that those types of companies we're seeing are structured the way they are as self pay programs because of the fact that essentially, to be honest, they're just wanting to make money off of the medication. A lot of them
Yes.
are integrated with a pharmacy and they are compounding. They'll even say there's disclaimers. I started to look into it just out of curiosity when I've seen this a lot, because this is one of the pushbacks I get from providers. Well, how does everybody else do this? So one other thing that I think is really important from the claims processing standpoint is to talk a little bit about the way that our industry is structured from that pay and chase model. So can you
Hmm.
explain a little bit of that with, these claims going out the door? We often hear as a rebuttal, especially from providers, well, they're paying my claims. Why is this a problem? Or it's an E&M. Why is it a problem if the pharmacy, says that they'll cover it, that type of thing?
Yeah, so what we find more often than not is yes, these claims do get paid because the insurance companies aren't requesting the documentation. They aren't physically seeing the documentation for that encounter, and a lot of times these are being done along with other chronic care management. They may not be conditions, so a lot of times with the coverage from insurance companies, they say that they will cover these certain services, but there has to be something that goes along with it. So they will cover this medication or management of this medication, but there has to be cardiovascular risks associated with that. And this is just detail that they don't get on that claim side unless they are requesting documentation. So basing your decision solely on something being paid is not going to give you a clear picture on if it is compliant or not, because a lot of times things are paid and documentation isn't reviewed by the payer, and things, it's just like this trickle down effect that this has been getting paid and then all of a sudden there's an audit and it's discovered that the documentation isn't compliant and they want their money back. So you have to be very mindful of what the different requirements are. And there's something else when you started talking about those online, which I know this kind of gets away from the claim side of things, but something that came to my mind is you and I are in different states. You are in Tennessee, I am in Florida. In Florida, there is a lot of services that cannot be offered through telehealth. Um, so, like, I wouldn't be able to go onto the HERS website and get mental health medication. I wouldn't be able to go on the HERS website and get weight loss medication just because of the state of Florida regulations and requirements surrounding those types of healthcare services. So you have to really look at a lot of different things before you start submitting claims, and how are you providing these services. I know telehealth is a really hot topic right now, but things like that HERS company is essentially a telehealth service that they are offering. So you have to pay attention to what is the coverage, and that's really hard to do on a mass basis, or even trying to look at a current patient population who's receiving these services or may qualify for these services, because you're probably not going to go through individually and verify that that particular coverage. And then, like I said, what happens if these claims are getting submitted? These services are being used to support evaluation and management services. So, not even just the cost of the medication, but we're talking about that evaluation and management service encounter that gets billed out when the patient is there for obesity and they're prescribing Zepbound. That's another popular one. But in my case, my insurance doesn't cover weight loss at all. So the provider technically shouldn't even be billing for that particular encounter if they're managing a weight loss medication and my coverage doesn't include any type of weight loss services.
Yeah. So, and I want to highlight that because that's been the overall context of what we're talking about here. But what you said related to the E&M service, This is why it's such an issue right now, because this type of management is being done and the E&M service is being built out. And, that really ties into the misconception as well and misunderstanding that just because a patient steps foot into practice or has a telehealth encounter, that it's automatically billable. The presence of seeing a provider alone does not equal medical necessity for an E&M service. So we have to be really careful with that. And, I think that telehealth point you brought up is really good, and that needs to be highlighted as well, because what I am seeing is that this is something that a lot of people are looking to set up as a telehealth program. So
Yes.
say, for example, there is a family practice or even a specialty. I mentioned rheumatology, maybe endocrinology, all of these others. What I'm seeing is that they're throwing around the idea of, within internal med or within their existing practice, setting up with a couple of providers a telehealth service line, really service line,
Hmm.
and they want to have all of these encounters taking place and bill, again, like we've been saying, with no understanding as to what actually happens. Now, I really predict and think that in the future, this is going to be a really big issue, because what happens in the industry, just like we saw with COVID services, with telehealth services, it's something where we're beginning to see it a lot on the initial review level. And again, it's going to take time for the payers to be requesting notes and looking to find this as an issue, but it's being done non-compliantly more than I can even, quantify at this point. If I notice a practice is utilizing this method for medical weight loss, it is being done incorrectly for at least some of the patients, if not for all of the patients, depending on their understanding in the mix with chronic conditions.
Yeah, I
Now,
I
oh,
agree
go
that
ahead.
I agree that it's being um it's done quite a bit. Just in my regular auditing, I can't tell you how many times the encounter is. So maybe this is something that you could speak to. Like I said, this is something that I have just started really diving into myself, is how um the weight loss programs and things affect compliance. And so a lot of times what I am seeing is the patient is coming in solely for their obesity. And so there's actually two scenarios. So what's your input on how we should code or audit situations where they're coming in solely for obesity with the prescription of weight loss medication, and then, which obviously that would be, we can't bill for those services unless we've verified that that patient has coverage. And then also, how can that impact the level of service for an E&M visit when, say, the patient has one other chronic condition that's stable, that's being managed, and the provider wants to bill a level 4, but technically we can't consider this obesity if it's not covered. One, if it's not an FDA approved drug or it's not part of the patient's coverage. How do you educate that to the providers, or how do you convey the impact of that?
So that question just brought to mind a situation that I had last year with a particular practice. I think they were more family practice. And, that my audit results sometimes are frustrating to people. I understand. I know I'm here to help you before, an investigator is looking at you, hopefully.
Yeah.
So I'm used to being that one frustrating people. And, we had a conversation, and from their clinical perspective, I 100% understand that obesity plays into the progression, the worsening of all of these other things that are happening. So diabetic patients, patients with hypertension, lipid issues. Obviously, if their weight's under control, that's in part going to improve all of these other things. But we don't see that in documentation. So to your point, what I have seen up to this moment is that we'll see, for example, let's say they're there for diabetes and that's controlled. They're going to renew the medication for that, and there's no other complaints. Then they separately talk about weight loss. And let's say that the drug being prescribed is not FDA approved for diabetes or for weight loss. In that situation, we have a problem because, like you said, we can't count it towards the chronic management. They've not tied in writing how obesity is impacting their thought process and their treatment of the diabetic patient. So we have no choice but to separate it out. Now, with that being said, this still gets very tricky because if you have that drug that is not covered in those indications or with those indications, you still have to push them through a self pay process to some extent because you have to show that that is a distinct, separate item that the patient is being billed for. Because essentially, you're just going to say, oh, well, they have chronic conditions, so we're doing it for free or as a part. Those are the type of ways it could look like afterwards in an audit or an investigation. Why aren't you charging them for this if that's what you're doing? So it's really problematic. And this goes into the next part of what I want to talk about today too, and that is lifestyle medicine. So we're hearing a lot now, and we're going to keep drugs out of this second part of the conversation here. So we're just talking in general practices that are wanting it's not that they're not wanting to provide a great service. I personally, seek out things like functional medicine and that
Mhm.
holistic mindset because it makes sense to me, right? How are you going to treat one particular area without accounting for everything that's playing into it? Again, I don't have specialists or, specific organ systems that are an issue. I want to throw that out there when I say this. But when it comes to my internal medicine type care that I seek out, functional medicine is a lot of times where I go. And it reminds me a lot of this lifestyle medicine because essentially what the practitioners are wanting to do is they're wanting to treat the patients from that perspective of, okay, what do we do at this point to stop the progression, to get this patient better, and to hopefully, reduce the risk factors. It's going to impact the overall health. But the problem is that the way that the system is set up, and this is going to make a lot of people mad. I know these conversations are not fun, but the way that the system is set up is they're not paying for anything that would be considered preventative unless it's within the bucket of those services that we already know exist. So this has become really difficult, Michelle, because, even last week, I had this conversation. I've been working on some projects with my good friend Terry Fletcher at Terry Fletcher Consulting, and, we had this conversation with a group, and the provider wants to do this. They care a lot about their patients, they care about the patient health. Clinically makes 100% sense. But from the compliance perspective, it's really hard to fit it into this puzzle of what exists and the parameters we have to stay within. And that's some of a little bit of the conversation we had. Yes, you want to do lifestyle medicine, but how does this look? Because a lot of times too, they are wanting to separate it out from chronic management. So if the patient's diabetic, they have hypertension, all of those, they still want to do lifestyle medicine, but they don't want to wrap it into those chronic follow-up visits related to existing conditions. So what are your thoughts on that, Michelle, from that perspective of, we have these parameters that we're stuck within? There's not a lot of different options if we're working through this type of review, even. It can be really difficult from, medical necessity perspective,
Mhm.
CPT coding perspective, diagnoses could become an issue. What are your thoughts on that?
So it really poses a conundrum on how to to try to prevent some of lifestyle medicine. Not only is it how, to treat the chronic condition, but for me, I also think about how we can prevent some of these chronic conditions. So looking at it from a patient perspective, I'm trying to personally prevent from down the road having all of these chronic conditions that can pose great risk to my health, that could lead to diabetes, heart disease, all of these types of things. But when we look at what's available for lifestyle medicine and the services that are provided, or, I mean, you can't even really say covered, because how many times, like, I think of medical nutrition therapy. Look at how many parameters surround medical nutrition therapy and who that's available to. And it's basically your diabetic patients or end stage renal patients. When we look at these services, there are a lot of parameters around these that prevent you from even implementing them into your practice. So when I think of lifestyle medicine, I think of medical nutrition therapy, smoking cessation. I know there's codes out there for that preventive counseling. It's kind of non-specific, where it says you spend 15 minutes counseling your patient on these things. And I think the thing that you have to remember with these is, one, how are they covered? And did you provide a substantive service to your patient? I don't think Medicare means, when they say these cover these things, that you have a one liner in your note to say, I counseled this patient on diet and exercise. Recommend they drink more water. Something non-specific like that. So
And
it's,
on every record, that statement
yes,
on
on
every
every
record.
record. So it's really difficult to even know where to begin, in my opinion, on how to implement this this more counseling based side to medicine, and encouraging the person to change their lifestyle to promote healthy habits, and in turn promote better health in their life. I definitely, like you, see the benefits of that, taking a more holistic approach and looking at the whole picture and how we can get to the root cause of a problem, instead of just constantly throwing things at symptoms, or trying to get you, just under these thresholds, and managing you the best we can. A lot of this does also require patient responsibility and agreement to carry out these lifestyle modifications that are being presented to them. So, like smoking cessation and medical nutrition therapy and things like that. So, it's really hard to know how to implement it, because I feel like, I'm not saying this is every patient out there, but some see this, you know, this magic pill is going to fix everything, and that's what I want, when really what needs to happen is you need to take a look at more of what are your activities like? Are you sitting at a desk, in front of a desk every day? That would be me. In front of my computer screen. Limited activity, and just, it's more of a counseling based service right now, and falls really more in the preventive category. So it's hard to even know how you would implement that
Yeah.
as a
And
whole separate line.
well, that's what's been so difficult in these conversations I'm having with providers directly, is that especially when we say counseling. So technically, we could bill an E&M on time if there's counseling involved, right?
Yes.
But we have to go back a step to medical necessity, which is subjective. And again, when we look at this from that preventative perspective, it's still going to be questioned. So it's not just, oh, we're meeting the requirement of a CPT code, we can bill it, no problem, whatever, who cares about the drug, all of that. That's why we have to dig in at this level. And, one of the things that is going to be very difficult to navigate with this. And depending, again, completely depending on the structure of the program. But one of the things that's difficult when you talk about nutrition based services, bringing in a licensed dietitian, nutritionist, maybe
Mhm.
even social workers, to be frank, not all of those services have high reimbursement rates. So we already
Correct.
get questions when we audit those types of practitioners due to the way that the fee schedules are structured. So when you then trace it back to that cost and that profitability perspective, that's where we come back to all of these questions again. Now, one of the things that I've thought about, and it would need to be a discussion, but there is a large component of this type of treatment when I talk directly with the providers that is really looking at the root cause that can drill into, for example, behavioral health. So
Mhm.
maybe that won't look like a physician taking care of that, but we're seeing a lot of integrations into family practice, pediatrics, internal medicine. And maybe this is a way that we're going to be able to integrate more, look at the big picture, but do it within the parameters that meet the requirement of compliance, and then hopefully, attack patients, real issues that they're dealing with to help with all of this. So,
Mhm.
there's not a good answer for it right now, other than the fact that you absolutely have to consider the self-pay program, or you're going to be out of compliance, because not every single patient 100% across the board, at least that I've seen over the past year, has met the requirements. Not to
Mhm.
say that some have not, because absolutely they have, but not everybody fits into this bucket, and it's going to be an issue when you get audited in the future. Now, Michelle, as far as the takeaway for the practices and really the consumer, the patient side, this is something too. We've talked previously about how practices will implement certain things as a courtesy almost for a patient, but also keeping in mind their own revenue cycle. This is something where I also think it's really important for practices to understand that they need to look at the cost of something like insurance verification. Because you had
Yes.
mentioned earlier, that is the only way you're going to know, ironclad what is going to be covered by a payer, what's appropriate to send out on a claim, and what the patient needs to be paying for.
Yeah, and that's actually, as you're sitting there talking about these different things, the cost of implementing that, that was one thing that came to my mind is what does the workflow look like for a practice who is trying to implement these kinds of services, and even just from the beginning of scheduling the appointment, and those employees as well having the knowledge that, hey, this is something we need to look into further, we need to verify their coverage. There's so much that has to happen before they even sit in the room with the provider to determine, is this going to be sent out on a claim to the payer, or is this going to be self-pay? So I think that there's so much more that goes into a, offering weight loss services than just having the provider meeting with the patient, prescribing them a medication, counseling them on lifestyle changes, and offering these other even lifestyle medicine services that we were talking about. Then, that just kind of still leaves you to the question, would it even be financially reasonable for a practice to implement some of these services?
Yeah, and that's a really big part of what I do when I work with my clients too, is when we identify coding issues, it doesn't stop there. We don't
Mhm.
keep the conversation at the level of what CPT code did you choose. You have to dig in, because every coding problem typically has some kind of trace back to a workflow that also needs to be considered, whether it is physically with staff in the office, like you're saying, or
Mhm.
if it's within, systems like workflows inside of EMRs. So every time there's a coding issue, we have to look at the whole picture and trace it back. And, that's something too where, at the end of the day, these conversations have to take place and we have to have the understandings very similar to actually the previous episode when we talked about ABNs. It's
Yes.
that same type of concept. It may be something that's never covered, so the ABN may not be automatically required, for example, but we have to think about that workflow of the provider even knowing, like, hey, yeah, I could prescribe you a medication, but today we were treating your 3 chronic conditions and we're going to have to talk to you about the way our program is set up. There's different options to consider. And that's another thing, and we don't have to dive into it now, but I just want to mention, from the provider's perspective, that's other input that you need to get when these people come to the table. You need clinical staff, you need compliance staff, and you need administrative staff at this table looking at the makeup of your program. Because something like that could cause a visit to go twice as long. And then,
Mhm.
we're back in that wheel of providers being frustrated that they have to have the conversation with the patient, or, that they have to say, hey, you've got to come back next week if you want to talk about this so we can look at, essentially billing for their time, that type of thing.
Yeah,
So yeah, it's just very messy and I'm
it
sure this
is.
is all overwhelming, especially if people have really not thought about it. But hopefully from our discussion today, you're able to take this back and have, good productive conversations about all of the possibilities, every angle you have to look at this from, and, really making sure that you have that coverage.
Yeah, and absolutely remember that compliance is not just about audits. Like Stephanie said, there is so much more that goes into compliance than just auditing your service. So you have to do your audits, but there also has to be follow up and regular monitoring. So say you've listened today, you've identified this as an issue in your practice. It you should do some type of internal audit to see where you stand with that, because the last thing you want to be doing is looking back after a payer has come to you and said, you know, this is an issue. So just remember that compliance isn't just about the audits, it's also about the follow up and what you do with the information that you've gotten from those audits. So the education, maybe workflows have to change, maybe templates have to change. I mean, a lot of providers use templates in their documentation, and so maybe they don't realize that there's an issue with how they're putting something in their template. So that education is just as important. And then of course, for us as auditors and coders, we need to educate ourselves and know how to research these things. I learned a lot from Stephanie today. As I said, I am just getting started and diving a little bit more into these weight loss programs. So it really is an eye opener, I think, that even going as far as making sure the medication is FDA approved. Like that's not your typical course of action when you're coding or auditing an encounter. So from an auditor's perspective, you have to dig in a little bit deeper than just saying checking these boxes for it meets this level of service of E&M. We have to also go that next step and see, is it even medically necessary? And sometimes that takes a little bit extra time.
Yeah, really good points. So, as always, we have our email address, auditingantics@gmail.com. You can also go to my website, stephanieallardconsulting.com, if you have any questions. I do offer a lot of compliance services there. So, if you are feeling lost, if you feel like you need audits as a result of this conversation you're hearing today, always happy to help. Just reach out. And if you have any questions, concerns, feedback, anything, we'd also love to hear about different topics that you'd like us to feature in the future. So thanks, and we will see you next week.
Bye.